Well, good morning and welcome to our September PDAP meeting. And I'd like to go ahead and get started with just some introductions. Mary Ann Lindeblad, board chair. We have another board member here in person.
Douglas Barthold, board member.
And then folks on the phone, board members on the phone. Eileen and Tom, do you introduce yourselves?
Yes, hi, Hong Chong, board member.
Eileen on. Well, we can expect Eileen, I think, at some point. She's not here. And then we have a new, soon-to-be fully appointed board member, but he's on the call today. Greg, if you could introduce yourself, maybe tell folks just really quickly a little bit about yourself.
Yeah, hi, thanks for having me. I look forward to fully participating in the board at the next meeting. My name is Greg Gibson. I'm a pharmacist by training. I've been in kind of clinical practice within UW Medicine at the hospital up here for about the last 10 years, and recently switched into more of a drug policy and utilization and cost role. So that's kind of my most recent specialization. I also play a large part in our pharmacy residency program up here. So kind of have a good ear to the ground for new professionals coming into the field. Great, and thanks for having me.
Well, welcome. So let's just quickly go around here with the staff that are here, and then we'll go to the staff on the phone. Ryan, do you want to start?
Sure. So I'm Ryan Bistaresi. I'm the Assistant Chief Pharmacy Officer here at Healthcare Authority.
Michael Tunick, Assistant Attorney General and Legal Counsel to the board.
Mike Newentwander, the Director for the Prescription Drug Affordability Board.
You did.
Okay.
I'm GP, I'm the cost and quality analyst.
Thank you. Simon?
I'm Simon Borman. I'm the policy analyst for the PDAP.
And folks on the phone?
Maybe
We'll start with Kelly.
Hey, I'm Kelly, and I'm the PDAP data analyst.
I think I saw Marina on there as well.
Yeah, this is Marina Suzuki. I'm a health economics research manager. I'll be helping you with the affordability review.
You sit down, I'll be later. Yeah. Anyone else you're expecting, Mike?
I think that's probably it for right now.
All right. Well, thank you. So let's go ahead and turn it over to Mike for the director's report.
Great. Yeah, thank you everyone for coming out today. Always love being able to meet together here in Olympia and work on some PDAB stuff. So some general updates, just as we heard, we've got our fifth and final board member here on track. So that'll be great to round out our board and have that done. And other things that are going on here, I know we were discussing last time some small tweaks to the Washington Administrative Code due to some other legislative efforts that have been done over this past spring. So one of those included when we do upper payment limits, simply making sure that we have clear start and end dates for public comment. And so that was one pretty easy fix to the WAC that we were able to put in. The other was the requirement for us to be able to share information between the Drug Price Transparency Program, the Healthcare Cost Transparency Board, and the PDAB. So it's a lot of acronyms: DPT, PDAB, and then HCCT. So just making sure that we can share some data between those. We went to the HCA Data Utilization Committee to make sure we were good in terms of internally being approved to share that data between the programs, and that was approved. So now we're working through the external review of that language change within the WAC. So that should be pretty quick and painless here for this part. And then as we develop other parts of the program, more fully, then we will continue to do updates to the WAC and our policies as well. So those are kind of the changes there. The other part that I was going to chat about was our draft for the annual board report that we need to submit to the legislature every December. So we sent that out in the materials, and basically it's just a rundown of what we've done over the past year in terms of creating the board, establishing the chair, establishing our policies, updating the rules and the policies that we're creating, creating our initial steps of creating the advisory group, which we'll talk a little bit more about here in a short while, and the development of the initial drug list, as well as just contracting with Portal to help us in terms of our program support and some of the education pieces that we've received over the past few months. So you can read those different parts of the report in more detail. It's not that long. It's 9 pages. So pretty quick read. A lot of that's bullet points as well. But that's the pretty close to the final version. It still has to go through a little bit more internal review before it gets submitted to the legislature in December. So any questions, thoughts, comments on those pieces? Okay. Great.
Good. All right. So let's go ahead and Mike, you're on again.
Yeah, and so for this next part, during our last meeting, we had discussed some of the, because we were creating the policy around the initial drug list and some of the language around a couple specific parts of that policy. And I think Doug was kind enough to bring that up to us from some of the comments that we received from industry. So we discussed that a little bit and wanted to go back and review it internally and also get some ideas in terms of precedent and legal support. And so we've brought that back. We've made a few tweaks to the policy, and Ryan is as our pharmacy guru here. Maybe he can dig into it a little bit more on some of the thoughts that we had, changes we made, and kind of the details and the reasoning behind what we've been discussing over the past month and a half or so.
Great, thank you, Mike. So as you may see, the eligible prescription drug policy is listed in your binder. For the most part, a lot of this has remained unchanged from the last meeting, but I will direct your attention to a few points that have been updated. So under number 2, the identifying the eligible prescription drugs for affordability review, under 1C, it just is clarified to say that each individual NDC we consider a drug product rather than a drug ingredient. I know that some of the public comment that we had received prior to the last meeting sought to have better understanding around how we were defining prescription drug within our statute. And going to the end on number 5 is a write-up for the explanation of our methodology and what we were able to determine after reviewing the statute. So in 5B, when looking at the RCW and the WAC, we've identified that the term prescription drug used means the drug ingredient. And whereas a 11-digit NDC is known as a drug product. So if we think about what the active ingredient is, a lisinopril, enalapril, carvedilol, kind of whatever the active ingredient is, that we are using that as the term, prescription drug. But when we're thinking about a lisinopril 10 milligram tablet made by a specific manufacturer, we'll call that a drug product. So that way we have clear terminology that will be used consistently, throughout this program. So in terms of the eligible prescription drug policy, we are looking at drugs at the ingredient level and at the drug product level. And when we've identified that drug products meet the thresholds as outlined in statute, that those can then be grouped up together as a single drug ingredient for a affordability review. So then that way you're not necessarily saying that you're doing an affordability review on just that 10 milligram tablet by that one manufacturer, you'll be looking at the manufacturer's set of that drug. So they're 10 milligrams, 5 milligrams, 20 milligrams, 40 milligrams, all kind of together as one eligibility review. So that is the biggest update from the previous version of the policy to the current version.
Any questions?
So essentially a prescription drug would, well, basically it's at this label, brand name, active ingredient, formulation level.
That's, yeah, so consistent with kind of how the statute is written. So when looking at RCW 6941-01010, it's talking about, how are these substances recognized in US Pharmacopoeia, or the substance that is used to treat, mitigate, cure, or alleviate the condition. So really, our statute is looking at what is that ingredient. And so thinking about how this applies to our statute, 7405, we're looking at it at that ingredient level. And then, so going back to the point that you were saying is that, so it's the same labeler, like I said, the same manufacturer, that same brand name, the active ingredient, and that formulation. So if we're thinking about a manufacturer that is making a oral tablet and then an oral solution, we would not necessarily group those together unless both the tablets and the solutions met that threshold.
Well, but if they did meet they'd have to, because there are different formulations, wouldn't those be two different drugs in our?
Yes, because, so we're saying the same formulation.
Okay, yep.
Any other question for Ryan? Right.
Okay. So yeah, that was kind of how we were working to address those questions that were brought up and clarify the why we're doing what we're doing behind that. So for this, what we wanted to do is give people, after we've explained it now, a little bit of time to look and digest, and also because we made some of these updates to the language, in case there's any public comment that comes in, to give them some time to look at that. So the idea was to discuss this, answer any questions that we had, and then approve it at the next board meeting in November.
So we'll vote on it then.
Yeah.
Okay. That's great. We ready for the next?
Okay.
All right. Simon, I think this is yours.
So the next task is to vote to appoint the advisory group members. And folks remember last meeting, we talked about there were 5 applicants. The advisory group, I'll go through and list off their names. The board members have all looked at their applications and have decided that they're okay with appointing all of them. So we have Jim Freeberg, Executive Director of the Patient Coalition of Washington, Ronnie Shore, pharmacist and president of Healthcare for All Washington, Laura Berry, CEO of Soundview Medical Supply, Tim Lynch, a pharmacist and senior vice president and chief administrative officer of Multicare, and Daria McGrew, PhD and director of state policy for pharma. We want to do a motion to vote.
So that's, so we need a motion in order to go ahead and appoint these advisory board members. Do I have a motion?
I move to vote.
Do I have a second?
Second.
Moved and seconded to approve the list of, advisory group members. To have a vote. All those in favor say aye.
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 Any opposed? Been moved, seconded, and voted, so we will officially appoint those 5 individuals to our advisory board. That was easy. Thank you.
Thank you. And so for those 5 members, I'll reach out soon and get you started on onboarding.
I actually, sorry to interrupt, I just wanted to say that we do have a quorum, so with the two members, in person, plus I see Representative Cody. Yes, and yes, we do have 4, yes, so all 4, 3 needed for a quorum.
Thank you for the reminder. So we're good.
I'll reach out to those appointed members and get them onboarded. Just as a reminder that the goal for that group is to help with the investigation of each drug selected by the board, and then to provide a written report to the board with their findings as to whether or how the drug will lead to excess costs. The expectations are a bi-monthly meeting of the advisory group, and then ideally attendance by the advisory group members at these bi-monthly PDAB meetings. They'll select a leader from within that core advisory group. They'll provide input on the first drugs that will be selected for their affordability review, and then they'll work on a final report to advise the PDAB on the excess cost of the drug. And the factors that go into that report are laid out in the advisory group policies that we all put together. And how exactly they'll go about putting together that report will be a matter for them to discuss in the first meeting. So looking forward to working with everyone.
So Simon, you'll be pulling them together?
I'll pull them together.
Okay. Thank you.
Yeah, and I think the idea is, as Simon mentioned, do every other month, but staggering it so that way, you know, they can kind of see what happens here, meet the next month, and then so we kind of every month there'll be something going on from our side, but that way they can kind of be updated with the decisions that you're making, and in the following month work to address any questions or things that they have on that. So. And you know, again, as this is all brand new with the advisory board, you know, there's going to be a little bit of a learning curve as we put this together, and then as we go through the drug selection process, you know, they'll give their input on that, and then we will work to expand and add additional members per the specific drugs that we're going to be reviewing that would have an expertise or a specific interest in those. So yeah, lots of good things to come. A little bit of you know, building the plane as we fly it type thing. But so far, I think we've been doing a pretty good job of that. So so yeah, that's kind of the next steps. And if the board members have any questions on, you know, the advisory group, again, always feel free to reach out. The other thing too is so the advisory group won't be subject to OPMA, as they're not like a decision-making body. You know, they're providing advice as in an advisory function. But so those meetings will probably be virtual, and you know, so we won't have to do quite the same setup as we do for our regular board meetings. And of course, the advisory board members are always welcome to attend these regular open public meetings and bring their findings forward as needed. So,
well, we look forward to meeting them.
Yeah.
So, great. All right. Well, now we're moving into the really part of the meeting today. So, we've got a presentation now talking about the data dashboard and the weighting of the drug selection criteria. So, what is Arshina and Jiping? Will be taking the lead on this one?
Yep. So, and just make sure Jinping, because sometimes the microphones don't pick up stuff super well. Just project and talk loud.
Good morning, everyone. This is Jinping. I'm the Cost and Quality Analytics Manager in the HCA. Today, we will continue the topic of selecting prescription drugs for affordability review. We will first go over the data measures that can help us select drugs for affordability review. Then we will discuss how to rank the drugs in the eligible drug list. And at the end, we will provide you a preview of the eligible dashboard, which can serve as a tool to help you select the drugs. And hopefully after this presentation and the following discussion, we are able to select the drugs to go on for the affordability review. The eligible drugs in the eligible drug for generic drugs, to be eligible on the list, it has to have a WAC cost of $100 or more for a 30-day supply or less, and at the same time has a price increase of 200% or more in the 12-month period. Among the 649 drugs we have identified, the most of drugs were qualified because its WAC cost is over $60,000 or more per year or per course of treatment. One question we need to think about is, should we select drugs from each of these categories, or should we just focus on the categories with the most eligible drugs? That is the prescription drugs with a WAC cost over $60,000 or more per year or per course of treatment. Before we let's first review what the statute has said about whether to conduct affordability review. When deciding whether to conduct affordability review, the board should consider the class of the prescription drug, whether any therapeutically equivalent prescription drugs are available for sale, the input from advisory groups, and the average out-of-pocket cost for the drug. Board can choose up to 24 drugs per year to conduct the review. We have touched the data measures for selecting drugs a little bit in our last meeting, and today we will go over this one by one. On the left side is the data measures the board should consider according to the legislature. And on the right side is the data measures we have created based on our discussion with the board members. The first one is the number of people using the drug. It was defined as the count of distinct individuals who had a claim for the specific prescription drugs in the 2022. It was a variable created based on Washington all-payer claim database. And over 70% of the Washington population was represented in this database. This slide shows the distribution of the number of people using the drug by eligible category. The number of people using the drug vary widely. There are some, for certain drugs, there are only very few people using the drug. And for drugs with less than 10 people using the drug, we can exclude them, or we can set up a threshold for the number of people using the drug. For selecting the drugs, for example, we can focus on the drugs with at least 2,000 people using the drug. The next measure is total plan paid amount. That's the dollar amount that was paid by the health plan. It is the cost to the insurers. The total plan paid amount was highest for drugs with a WAC cost of $60,000 or more per year or per course of treatment. The median of the total plan paid amount is over $465,000, and the mean is over $8 million. The corresponding measure is the average plan paid amount. That's the dollar amount per person per year that was paid by the health plan. For drugs with a WAC cost over $60,000 or more per year or per course of treatment, The median average plan paid amount is over $17,000 and the mean is over $37,000. The total out-of-pocket cost measures what the patient has paid for the drug. It is the sum of co-pay, co-insurance, and deductibles. For drugs with a WAC cost over $60,000 or more, the median total out-of-pocket cost is over $10,000, and the mean is $236,000. Average out-of-pocket cost measures the dollar amount per person per year that was paid by the patient. For drugs with a WAC cost over $60,000 or more, the median average out-of-pocket cost is $269. The mean is $776. The total paid amount look at what the patient total amount paid by the health plan and patients. Understand it as a total cost to the society. The total paid amount was highest for drugs with a WAC cost over $60,000 or more per year or per course of treatment, and the median is $485,000, and the mean is over 8 million. And the average paid amount is the dollar amount that was paid by health plan and patients per person per year. With a WAC cost over $60,000 or more, and the median average paid amount is $17,000, and the mean is $38,000. The next measure is the patient liability. It looked at what the patient has paid relative to the total cost of the drug. The higher the patient liability, the higher the patient burden. The patient liability ranges from 0% to over 60%.
Real quick, hold on, Jean. So that was a lot of information and statistics in a relatively short period of time. And I know each of these tables has a lot of numbers on it. So just want to stop just for a sec and give the board members a breather. Do you have questions on what she's been talking about or what some of this stuff means?
Hey, Mike, I have a question.
Go for it.
It's Hung, board member. On the total paid amount on some of these, it's from the insurance report, right? The Washington ACP. That's just the payer reporting out.
Yes,
is that the net cost that we're looking at, or is that just, and what I mean net cost is after rebates are applied, or is that before any of that? Do we know?
the growth of rebates, because it's what actually showed on the claims. I don't think it rebates.
Hi, Hung, this is Donna. The data set, the all payer claims database, I believe is what was being used, and that does not include rebates.
Okay, so the amount could be significantly lower. We just don't know.
Not necessarily for copay or for patient coinsurance. Typically, rebates are not passed through to the patient at the point of sale. So the total paid amount might be significantly lower, but the patient out of pocket would
it won't affect out of pocket. Just I understand that.
The total plan paid as well should be a lot lower, or could be a lot lower.
Could be.
But we also probably missing like manufacturing coupons and so forth that do affect out of pocket. And we probably don't have that either. I would assume.
I think that's part of the affordability.
Yes, I'm. Ryan.
Oh, I think the patient copay assistance is one of the criteria that would come up in the affordability review phase. But I think as we are looking at the eligibility, that's information that we can't request from the manufacturers yet until we know which drugs would be subject to the affordability review. But I can just double check the citation on that.
Okay, thank you for the information, Ryan and Donna.
Any other questions on these tables here with the various data points? Okay, great.
And Hunt, just to confirm it, yeah. So the dollar value and accessibility of patient assistance programs offered by the manufacturer for the drug is one of the criteria that the board shall consider when conducting a review. So right now we don't have that data, but if you select, drug X, we can go to drug X's manufacturer and request that data be provided for the board to consider.
Okay, any other questions? Okay, great. When we go through large buckets of data, I like to take a moment to breathe and pause for a second, just in case someone feels like the slides are passing them by. So okay, thank you, Jinping. And we can keep going.
Next measure is therapeutic equivalent availability. It was defined as to have the same ingredients in the same concentration with the same pharmacokinetics. If any of these factors differ, the drugs are not considered as substitutable. It was a variable that was created based on the first data bank database. And in our analysis, if the biologic product has a biosimilar, it is also considered as having a therapeutic equivalent. If the drug has the same active chemical ingredient, dosage strengths, and dosage form as the brand name drug, and we think that this brand name drug has a generic. Last but not least, we check if the drug meets multiple thresholds of the legislative definition. Remember, at the beginning of the presentation, I stated that the drugs were identified through 4 separate processes. So if some of the drugs can meet multiple thresholds. Overall, there are 4.
I just have a question about the generic availability. And this might apply to the therapeutic equivalence as well. But so same dosage strength is we're requiring that to determine if a generic is available. And that's not the same level of identification that we use when we're defining a prescription drug, as Ryan was telling us before. So like the generic, whatever, lisinopril at 10 milligrams, but not at 15 milligrams. We're saying there's no generic available for the 15 milligram one.
So this is Ryan. I'm just double checking what we had in C. So it was the same labeler, brand name, active ingredient, and formulation. So here, the difference is in the strength.
Mm-hmm.
And so there are some situations I know in which different strengths may or may not be generically available depending on patent.
Mm-hmm.
Whereas in this is identifying it as the same ingredient from that same manufacturer.
Yeah, and I agree with what we're doing on the eligible drug list policy. I'm just curious if here this should be if we're getting to the spirit of what we're trying to do here, because I can understand, if there's a huge difference in the dosage strength, then yeah, we would say that like there's not a generic equivalent of one or the other. But like the example I gave, where like if you think about it, actually maybe a better example is a 10 and a 20.
where if there's a generic availability for the 10, but not for the 20, we of course think that there's a generic available for the 20 because you can just take two 10s. So does that, I mean, I just, is this how First Data Bank also defines a generic availability, or did we just decide that?
I think this is how they decide it because this is at the drug product level, so the NDC level. I think that's kind of where that comes in because we're looking at a GPI 14, which then groups all of the drug strength, dosage form, and ingredient. So that's kind of how their hierarchy is. Oh, GPI 14 for Medispan, and then GCN sequence number for First Data Bank. Sorry.
Okay.
But yeah, I believe that's how their drug reference table is set up.
Okay. Well, I mean, so I guess that's sort of we're just taking what we can get from that data. But I think we'll want to be careful about using this when we're weighting our criteria. And I guess we'll eventually be able to look at this if we do an affordability review and we decide on a drug. We wouldn't want to deem something unaffordable that has a generic equivalent at a different dose. And I guess if there's any way that we can remove dosage strength from this definition, that would be great. But if that's just what we have for First Data Bank, then we just have to keep that in mind as we use this this variable going forward.
So this is Ryan, and one thing that we could do is we could pull the data as it is defined in First Data Bank and then do a group at that ingredient level. So that way, if half of the products, half of the NDCs have a generic and half don't, we could then group it up as the ingredient and say there is a generic for this ingredient.
I like that a lot.
Okay, so that's a step that I think we'll want to do as we're putting the generic availability together.
And I don't know if there's a similar issue with therapeutic equivalent availability. I haven't read that one in as much detail yet.
So this is Ryan. Looking at this methodology, we would be using the Orange Book, which I believe is at that NDC level to say what's AB rated, what's B rated. So we could also do something similar where we get the individual ones for those NDCs and can lump it up at the ingredient level to say, here are some AB rated generics and even, other A or B rated generics for that ingredient or for that brand alternative.
Okay. I think that sounds great. I mean, this doesn't have the dosage restriction though, from what I'm seeing here.
So I'm curious of when you're saying dosage, I think on the previous slide, it might have been a little confusing where it says dosage strength. It would be the same dose. It would be the same strength. So I'm not sure when you're using dosage, what that means to you.
I was thinking about the distinction between like a 10 milligram pill and a 20 milligram pill.
So that would be two different dosage strengths.
Right, and I think that's a problem then, because then we would say that one of those has generic availability. Like let's say that we say that the 10 milligrams has generic availability, but then 20 doesn't. Because there is no generic 20, but just because there's no generic 20 doesn't mean you couldn't take two of the generic 10s. And so that's why I think that's why I think Ryan's solution was good, was to sort of consolidate at the ingredient level with this information.
Yeah, we might want to talk about that because oftentimes, just because that assumes that 210 milligrams is cheaper than 120. Which isn't always the case. So I think we'd have to consider that on a case-by-case basis where it makes sense to do that.
Yeah, I think, Doug, you're talking about if, let's say, the 20 milligrams is a brand because they just increase the dose and then they make it into the brand. They're just worried about that, right? That's the example.
Yeah,
Yeah, and you know, most providers, if it makes sense to prescribe 210s for 20 instead of using the brand, they would. I think most insurance will probably restrict that type of scenario, right?
Yeah.
It's like we're not gonna let you fill for the brand. It's
that's
not
great.
it's not formulary.
I agree, like, that's what providers should do. But for us, as we make a policy about, if we're going to set an upper payment limit, we wouldn't want to set an upper payment limit on that 20 milligram branded one when
Absolutely.
there's already
Absolutely.
something that they can substitute for it.
Yep.
Well, and I think too, there's a couple, so when it comes to like, especially as we're going into like upper payment limit territory, we will have the drug review, which will go into a lot more depth, right? This level right now is just a little bit more of a course filter, which again, without rebates and all this other stuff isn't going to be perfect, but it's trying to get us in the ballpark of, do we think this is a drug that's worth reviewing? So, I definitely think when it comes to like you're concerned about upper payment limits and kind of getting into the nitty gritty of stuff, that's where the drug review will go into a lot more of the detail. Where again, this is just trying to help us eliminate.
Yep, sounds good.
So.
There are 14 drugs with multiple thresholds. There is one drug with a WAC cost of over $60,000 or more per year of course of treatment. At the same time, has a price increase over 50% over 12 months period. And there are 13 drugs has a price increase of 50% over 1 year, and at the same time has a price increase over 50% or more over 3 years. We have went through all the data measures, and we have to prioritize our data measures so that we can just look at limited number of data measures and to make decisions. In our last board meeting, we have agreed to prioritize the 6 data measures. They are the number of people using the drug, average out-of-pocket cost, total out-of-pocket cost, total paid amount. Also, we need to think about whether the drug has a therapeutic equivalent or generic drug for the brand name drug. The lack of therapeutic equivalent in the market limits competition and may contribute to the high price or price increase. And when a drug has a therapeutic equivalent, should we deprioritize the drug? And at the same time, we need to think about with the therapeutic equivalent drugs was widely used in the market, and the price difference between the prescription drug and the therapeutic equivalent drugs. Yeah, just something we need to think about. And also, if the drug meets multiple thresholds of the legislative definition, shall we prioritize these drugs? We have the drug list and also the prioritized data measures, how to rank the drugs in the eligible drug list. Colorado has done this through a dashboard. They prioritize their drugs through a weighting and ranking process. And the 5 data measures they have decided to prioritize are patient count, change in the WAC price, patient out-of-pocket cost, total paid amount, and average paid per person per year. For these 5 prioritized measures, they ask each board member to rank these 5 measures and sum up the rank to get the total rank. So the number 1 ranked data measure is the total utilization. The second one is WAC's pricing change. The third one is patient out-of-pocket cost per person per year. And the fourth one is total paid amount. This one is average paid per person per year. Then they asked each board member how much more important is number 1 compared to number 2, and how much important is number 2 compared to number 3. When they ask how much important number 4 compared to number 5, the first board member thinks that Number 5 is 25 more important than number 4 is 25% more important than number 5. And all the other members think that there is no difference in importance. After they got the relative importance from each board member, they average it and further normalize it to 100% to get the weights. They apply the weights to each of the data measure and sum them together to get the score. And their final list was sorted based on the ranking of the rank of the scores. One limitation of this method is that the score is calculated based on data measures in different units. 3 of these measures are in dollar amount, and 1 is just a number count, and the other one is the proportion. So it makes the final the score hard to explain, because what does it mean to add a dollar amount with a count with a proportion? Because of this, the limitation in the Paradox method, and we hope to we're proposing three different methods that's more simple and straightforward. The first method is to sort the drug list by the selected selected data measures sequentially.
Next, before we get into these methods, so this is you're proposing methods that could be used to the Colorado weights?
In place of.
Okay, because I think my understanding was that our sort of weight system was a little different than theirs.
Yeah, and so that was some of the questions. Is when we were talking between the last meeting and this meeting, there was some concern around how will this weighting work, and trying to figure out the best way to do that. And so we were looking more in depth around Colorado's and how they did it, and some of the difficulties around that, and because one of the things we're trying to do is come up with a clear way that I think what we're trying to do is avoid anything that's looks like it's just kind of art, right? Because as we're going to be selecting these drugs, we want a clear way that we're going to do this. And so sometimes it can be a little bit difficult to understand with the weightings and rankings, and that was some of the questions. Is like, how exactly are we going to implement this in a clear, concise way? And so we were looking at the Colorado way, and this seems like it could be a little bit more difficult than maybe it needs to be. And so that's why then Jinping's like, okay, here's a couple other proposals of things that we could do to try and maybe do it more simplified, cleaner, and kind of to the point of what we're hoping to get to.
I think I agree with that. Certainly, like the actual the application of the weights, I'm eager to see what she has in store for us for that. But this, how we arrive at that column G there, the basic normalized weights there. I think that our system was better than theirs for like having the board members allocate whatever we have 25 points to allocate 25 points, and then use those to calculate a weight on each of these criteria, and then apply and basically arrive at column G that way, rather than this like how much more important is this to you than that. So I guess like, are we gonna? Is that what, are we sticking with that? I guess like I'd like to see what we're using for our weights.
Yeah, so we've so not everyone gave us their weights too with the other things. We weren't able to actually like go through and finish that because there's again that question of exactly how does this work? So then we've come up with some other ways that's maybe not quite so much around the weights, but more just around a prioritization of sorting. And so Jinping will walk through some of these other scenarios to again maybe just a little more clear cut, simplified, to the point.
Okay. Well, yeah. I mean, I think that whether we do a priority, if we just have to rank the criteria, just like they did, I don't like that because it assumes that the difference between 1 and 2 is the same as the difference between 4 and 5. Whereas, like, I don't know if you look at the weights that I submitted, but I gave 0 points to most of the criteria. Then I gave almost all my points to 2 of them. And I gave like 1 point to something else. So then that's how I allocated my 25 points, because that's what I think is important. So I do think that that's a better way to do it than just a straight up ranking. I also completely agree that this is an incredibly important and complex thing. And so, like, I think the board should discuss that with each other too, and I don't know if that's on the schedule for today or next time or whatever, but then we can then discuss, why we're giving our weights the way we are.
Yep, and we'll have time to chat.
Great.
So just trying to walk through some options of possible ways to think about this here.
Cool. And just somewhat related, I assume when Greg joins the board, he will also be voting on the weights or the ranks or whatever. Yeah. Okay, great. Yeah.
I concur with Doug about giving us an opportunity to make a case on why we rank a certain way.
Yep. Yeah. No. Don't worry. There'll definitely be time for discussion. So
great.
The first method we proposed is to sort the drug list by the selected drug data measures sequentially. So we can sort the drug list first by the average out-of-pocket cost, then by the total of out-of-pocket cost, then by the total paid amount, and lastly by the number of people using the drug. It will give us a sorted drug list. But the order of the variables that we selected to sort matters. So if we decided to sort by the number of people using the drug first, then by the average out-of-pocket cost, then by the total paid amount, it will give us a very different list. And the problem with this method is that it looks like that we are sorting by 3 variables. After we sort by the number of people using the drug, unless there is a tie, it will not be sorted by the second or third variable. So the list is mainly like driven by the first variable we have choose to sort. The second method is to sort the most important data measure and then look at the rank of the other 2 measures. If you feel strongly about one measure, for example, here, if we think that the number of people using the drugs was the most important data measure when we selecting the drugs, we can
hold on 1 second. I know Jinping Kelly is just looking for making sure she's got the right thing.
So if we think that the number of people was the most important factor, we can sort this from the highest to the lowest. And this slide shows the top 40 drugs with the highest number of people using the drug. Then we can look at the 2 other dimensions of this drug. That's the average out-of-pocket cost and the total paid amount. We can rank these drugs by average out-of-pocket cost and by total paid amount to get the rank and some of these ranks. Here, the third row. The third row is the drug with the third highest number of people using the drug. This drug ranked 48th in the average out-of-pocket cost and ranked number 1 on the total paid amount. So we may want to prioritize this drug over the first one that has the highest number of people using the drug, while the average out-of-pocket cost only ranked 125 and the total paid amount only ranked 8th. The third method we propose is a little bit different because we sort the drugs individually by the prioritized data measures, then look at the sum of the rank of these data measures.
Are you changing slides?
Advance the slide. Maybe get back to the presentation.
After each ranking, we will get the individual rank and we can sum up these ranks to get the final rank. So here, this method, we put equal weight for each of these variables, and it also helps solve the problem of adding data measures in different units, because here we are just adding the ranks to get the total rank.
So I like method 3. I think it's the closest to what we want, but I think it can be improved further by weighting each of like the 4 variables here. So I think we identified 6 variables, so we would have 6. So we'd have 6. Each drug would have 6 different numbers. We would weight those by the average number of points given by the board members to that variable. Does that make sense? I mean, I don't think that's like. I don't think it would be like much more difficult than exactly what's done right here. Because like you said, this treats all 4 variables equally. But like, let's say that the board members gave 90% of their points to variable 1, then that should get a 0.9 weight, and then the other 0.1 gets allocated for the other 3 variables.
So this is Donna. Are we still talking? I thought this method did not include the board members providing points. It was really just ranking based on where it fell. Based on the data that's here. There's no subjectivity to this method.
Yeah, so right now this one is just based on, you know, where each of these data points falls within their respective lists and adding it together. So yeah, so this one, as Jinping is showing, it does not have the weighting or added to the rankings.
But those variables were chosen by the board.
Yeah.
So there's a little bit of sort of subjectivity there.
Yeah. So I mean, the variables themselves are, you know, this is what the board feels is important. But then Doug is suggesting adding the weighting to these ranks to get us a modified list with the weights and ranks combined. And so that's not what Jinping was talking about. That's what Doug is suggesting that we could do. And so those are, I think
the rankings are really useful because, like you said, it allows you to compare one that measures dollars to one that's a binary measure to one that is like a number of users. The rankings sort of, you know, they take care of that unit problem, and then just in order to account for the fact that we think different variables are more important than others, but maybe all are still important. That's where the weights come in.
Add the weights into this exercise to come up with the final rank.
Yeah, so like the column G on slide 35, like you basically take the weighted average of the variables using those weights from column G, except our column G from the Washington PDAB is going to be way better. So, but really it is.
Okay, well, let's maybe we can go through the rest of Jingping's presentation here, and then we can kind of dig more into have open discussion on the methodologies and kind of the next steps that we want to go through. So
we are developing a eligible drug dashboard to help you to select the drugs. We want to give you a quick look at this dashboard. So in the summary page, it shows the composition of the drug list by the eligible category, and also show the top 10 drugs in terms of number of people using the drug, and top 10 drugs for the total paid amount. And on the up right side is the distribution of the WAC cost for drugs with a WAC cost over $60,000 or more per year of course of treatment. We also have a lookup page. You can look up by NDC to look at the drugs details information. Like the example here is Humira. It was eligible because the WAC cost is over $50,000 or more per year of course of treatment, and the therapeutic class is an anti-inflammatory TNF inhibitor. It has a therapeutic equivalent. In 2022, Washington has 33 people using this drug, and the average out-of-pocket cost is over like $1,000. And the patients bear about like 5% of the total cost. In the next page, we listed the drugs that meet multiple thresholds of the legislative definition. Like the first one is the COPD drugs, which were qualified because it met, like it increased the price 15% over 1 year, and at the same time increased its price over 50% for 3 years. We can like work on to modify this dashboard to make it work with you, for you, and you can play with it, and so to choose which method is the best one. So we hope that after this presentation, we can finalize the data measures that we want to prioritize and finalize the methodology. We have the Coronado's method and the other 3 methods, and we can incorporate the weight into the ranking process for our final, like to choose it as our final criteria to sort the drug list. And we'll be developing and modifying this dashboard to make it available for you to choose the drug. And our final step is just to select the drugs for affordability review. I think we can discuss how to improve the methodology.
okay. So then I think this brings us to the part that everybody's been eagerly awaiting here. So
Maybe just me.
like I say, Doug looks excited. So
But actually, are we going to talk about the dashboard at all? Or do you want to go to
yeah, or any questions you guys have on the dashboard?
I just want to say I think it looks great. And so is that live? I mean, I assume that's not live to the public, but it's
still in a draft. It's still in a draft mode. We need to get approval to share it.
First, we have to finalize it.
Yeah, finalize it and then approval to share it for the board to play with. So,
And so that'll be for the 455 drugs that are eligible for affordability.
yeah, so you can look up the information on them and
Pretty cool.
kind of see. Yeah,
And and we're just kind of listing all the data that we have about them at this point, regardless of what we think of it, if we think that data is important or not.
yeah, I mean, it has, quite a bit of information on it related to each of the drugs.
And will it say so? Will there be any display of sort of like the information about the data and methods, like, oh, this number was calculated in the Washington all payer claims database, which represents this set of plans and comprises 70% of Washington, something like that.
Thinking.
Yeah, we can add that into the background.
I mean, as a side note, maybe this is a topic for a bigger discussion, but you could definitely write, you could publish a peer reviewed journal article about these methods. I think it would be well received and very interesting. But anyway, that was actually a separate question I had, so I'll bring that up later.
Any other questions on the dashboard?
Do you anticipate that the dashboard will have a flow of here's eligible, and then you read down to the ones that we do the ones we do the affordability review, and then we'll display the results of that separately, and then we'll kind of have this flow the funnel of fewer and fewer drugs.
As the rank is the way we should use. We can show the final list in another page as the top drugs we should consider for.
Yes, Eileen, I had a question. On the drugs that are on multiple lists. So this kind of goes back to earlier discussions about the quantity, like of the nitroglycerin patch, that it's all these different doses. So if I guess I'm trying to figure out would we treat that the same, or each individual one would have to have it if we decided to do a drug review, would have to decide for each one?
And so with the different dosages, Ryan, correct me if I'm wrong, we were going to treat all of those as a single drug review.
Right. Yeah. So this is Ryan. So if we're looking at the list that's up here now, like that nitro DUR you see, it's on there a few different times as a drug that had over a 15% and over a 50% increase. So if you were interested in nitro DUR, that could be one individual drug review, and we would look at all those NDCs. We would look at the different utilization. We might see that some of those NDCs don't have any utilization, but others do. And from there, then we'd be able to kind of track down and create a more robust affordability review that actually looks at what impact this drug and this price increase has on Washingtonians.
All right, good, thanks. That's what I was just trying to clarify in my mind, how that would work. So thanks.
Okie doke. Any other questions on the dashboard? Okay, well, let's maybe hop in here a little bit more deeper into the weighting discussion and some of our options there. So again, kind of what Jinping was saying is go through and we have some options in terms of sorting the selected data measures sequentially. So, just picking, so say we say utilization, we talk amongst ourselves, and everyone decides that, you know, utilization is the first way we want to organize it, and then just go through and then sort and whittle that list down to a smaller list using the other measures as the board votes in order of importance to get us a smaller list to pick from. Or if we want to you know, pick a count first and then look at the ranking, or if we want to do the sum of the rankings to kind of to pick that out, or as Doug was suggesting, then add the weighting to the sum. So I guess kind of opening that up here for questions, comments, thoughts, ideas, and what the board is pondering.
I'm still pondering.
Everyone knows my thoughts.
I do like, though, like, I would support.
Also, can I ask,
suggesting, I mean, that makes sense to me.
So Marianne, have you submitted the weights that like votes that
I believe I submitted them. Yes. But I'll be honest with you, I can't remember how
I had to look mine up, but
yeah.
How about Hung and Eileen? Have you guys thought about the weights?
Well, I guess that I kind of wanted to look over the numbers and see where things are at. It's hard for me to know at this point. I think that like ranking the number of people that it affects is important, but then I also want to look at what the high cost it is too. So you know, it's like I guess I haven't decided.
Haven't thought about it as much, Doug. I think total pay and number of people on it. I think it's up there for me. But you know, I stepped out when Donna came in to talk about that, you know, I think she mentioned something about we're not looking at the ranking, where we just look at this objectively, just by the number itself. I'm sorry, I missed that discussion. I also like that as well.
Right. So this is Donna. Yeah. So my suggestion was to do this, you know, not assign points and just to look at the rank. And I'd have to go back and remember my math in my head to remember if the higher the number was the least affordable or if the lower number was the least affordable. But I think it's the lower numbers are the ones that are least affordable, and that we would just go by rank here without applying weights. But that kind of treats everything equally. But I understand the desire to kind of choose which one of these four may feel that you may feel is more important than the others.
Yeah, the reason why I definitely agree that the simplicity of this is really nice, but like so in our I guess our previous decisions, we've decided on the 6 variables, right? And so in my opinion, so for example, if the drug meets multiple thresholds, I gave that 0 points because I don't think that affects patient affordability at all. The fact that it met three different thresholds to get onto the eligible drug list, that says nothing about what patients are paying. And so I give that 0 points. And so I don't want it going into like at least my contribution to our decision about affordability reviews, like that ranking for drugs, I don't want in there. I have feelings about the other 5 variables as well, and I think that all the other board members will too. And so I think that's why I like this weighting method, just to express our preferences.
Well, because there's the 4 ranks, which that you know, that have the dollars or the usage. So you know, there's quite a varied. The other 2 ranks are, you know, does it meet multiple thresholds, and is there a therapeutic equivalent? So they're both kind of binary, yes or no. So when we get the list, we can see, you know, here's our rank of this other stuff. But you know, say for example, because we don't want to look at all 400 some odd drugs, right? That's like too much. But if we can use this to get it down and like, okay, here's the, based on our sorting or ranking criteria, here's the top 25, and then you can see the binary selection on the other side, right? Saying, okay, and this drug does meet multiple thresholds, and this drug also has a therapeutic equivalent. So then like if we're looking at those top 25 and like, oh, this one does have a generic or something, maybe we just toss that one off the list, or if there's 5 that have a generic, we can toss those off the list, which then takes our list of 25 down to 20.
Yeah.
And then that makes it easier to.
So I take your point that like these two variables that are binary, you're gonna have less less variation in
they're more informational, I guess is the way I would look at them.
You can still rank according to the binary, but it's just there's gonna be a bunch that do and a bunch that don't.
Yeah.
And then they're ranked, so a bunch of number ones and a bunch of number twos. But and so like so just again speaking from my own opinion, like I could get talked into that type of thing where we like use those as a secondary thing, these binary ones. But even within the four numeric ones, I still think that weights are really important there. And I can give some more, like there within those 4, I gave all my points to 2 of them and 0 to 2 others. Like for instance, there's a lot of redundancy between number of people using the drug and the total out of pocket and the total paid, because those are all weighted by the number of people using the drug. And so if we give equal rank to all 4 of these, equal weight to all 4 of these, we're giving extra weight to number of people using the drug because that factors into total out of pocket and total paid. So, like I gave all my within those 4, I gave a lot to total out of pocket because that captures the total out of pocket burden for this whole state. And then I also give a lot to mean out of pocket because that captures if there's going to be a mean out of pocket among users, because that captures if there's some very expensive drugs for a small set of people who maybe aren't. Maybe it's not a big population within the state, and so if we miss that for the total out of pocket for the state, but mean out of pocket captures it. Anyway, I'll just say I think that I feel strongly that the weights should go into whatever our kind of, I don't want to call it a sum of ranks. I think it should be like a weighted average of ranks.
Weighted sum.
So Doug, this is Donna. Are you suggesting possibly removing maybe the total out of pocket?
No.
Variable?
Actually, I gave most of my points to total out of pocket, but I'm not suggesting remove any of them, because like I recognize the other board members are going to have different preferences for what they think is important. The degree to which how do we define affordability? Is it like is it if 100% of Washingtonians have to pay like I don't know $200 a month for a drug, or if 1% of Washingtonians have to pay $1,000 for a drug? How do we weight those two? And that to me is just a matter of preference. And so I think that like the board members submitting their weights to describe how they give preference to these different measures is a good way of like, I don't know, reflecting the will of the board in this final ranking.
Yeah, and I also want to point out that patient out of affordability to the consumer is only one factor in determining affordability. We're looking at the total affordability of the drug, to the plans, because that impacts premiums as well, and premiums is not part of this measure. So I just want to caution on ranking consumer out-of-pocket cost, really high compared to the average, to the total paid amount.
And
oh no, I was just, Don, I appreciate you just saying that, because that's what I've been sitting here thinking about, is really about, so there's the cost to the individual, but then there's the overall cost in terms of what it does to drive the premium. So is it to an individual, or do you think about it spreading across the population that is being served by this particular health plan? And what? So
well, an out-of-pocket is based on the insurance you have on the plan you buy. I mean, if I have a high deductible, my out-of-pocket's gonna be high. Yep. Sorry, and And it's also based on formulary, on where it is and with the payer formulary. So
All those come into play with this. And so it's getting down to, do you have 4 or 5 variables, or do you go out to something that becomes almost ridiculous?
I recognize that these things, and I totally take the point about effects on premiums. But, you know, as this stands, we don't have any reason to believe that, let's say that we are able to reduce, if we so the total like plan amount, or just even the total paid, which if we can somehow reduce that, maybe we should save the insurers a bunch of money. And the actual resulting improvement in affordability, like via premiums, is very indirect and long-term and affects all of Washington, which is good, as opposed to affecting the people who are, you know, for whom this drug may be very unaffordable for, and that we can get without by ranking with out-of-pocket costs. Like we like, as far as I know, we can't even see the premiums, right?
So this is Ryan. I think, you know, premiums may be one of the criteria that you will be able to get. We do get some of that information through our prescription drug our drug price transparency program, which we may be able to use because they can share data. I was just going to follow up to what Donna was saying earlier, is that, you know, at the phase that we're in, it's saying that, you know, for prescription drugs chosen for an affordability review, the board must determine whether the prescription drug has led or will lead to excess cost to patients. And then excess costs is defined earlier in statute as the cost of appropriate utilization of a prescription drug that exceeds the therapeutic benefit relative to other alternative treatments, or the cost of appropriate utilization of a prescription drug that are not sustainable to private and public healthcare systems over a 10-year time frame. So I think, to Donna's point, when you're thinking about the premiums, I think that is where that part of excess costs come in. And I do think, you know, to your point, that out-of-pocket cost does fit within, you know, what is sustainable, because if patients can't afford their out-of-pocket cost because everything is a high deductible health plan in the future, because that is where the healthcare system is going, then I think, you know, that fits in as the criteria. But I do see why we have the 6 that we have right now.
You can also, like, sort of on a similar vein, if you think that high out-of-pocket costs leads to poor adherence and just generally worse health, then that can lead to unsustainable costs to the healthcare system as a whole and to the plans via other types of medical costs that go down the road from poor adherence. So actually that's really helpful though to hear like how we should be this excess cost definition as sort of our target measure of affordability
when doing the affordability review.
Yeah, and we'll be discussing that more.
I saw that on the agenda
later today.
Yes.
As well. So if you're interested in that, we're going to have a lot more meat and potatoes on that specific topic shortly. So in terms of this, and again, so this is just to help us rank it and get it, you know, get us down to our top, you know, whatever 25 that we, you know, take it from 400 to our top 25 that we want to look at. So once we get the list, you know, these other variables it's not like they're going to disappear, right? Like we'll still be able to see those variables within that list, and then, you know, be able to consider that when we go through it. But here is just helping us to get them to the top of the list to take a look at.
So Mike, I usually agree with you when you say let's just cut down the list here. Let's just like use this simple measure to cut down the list. But I don't think the weighting is like our weighting is it's not going to be a complicated thing to incorporate to get a weighted sum of ranks rather than just the sum of ranks.
Yeah.
And so I do think that, again, this is just my opinion. I don't know if we should vote on it or whatever, but I do think that like without the weights, it's a significantly biased measure towards that, you know, that certainly doesn't reflect my preferences for how to prioritize the drugs.
Yeah, and I'm not saying we shouldn't, but I'm just saying like even with the ranks, it's not like it's not, you know, if you have a preference for one thing over the other, it's not like the others are going to disappear, right? When that final list comes, you know, we can still see everything, and then, you know, choose based on all the info.
Okay.
But that being said, then we need to kind of, Doug, I think I know where you're wanting to go on this. But with Eileen and Marianne and Hung, I guess thoughts in terms of ranking, selection, and how you would like us to see this list put together.
Well, I would say just sitting here listening to this conversation that I appreciate the idea of doing some weighting, because to me, the bottom line is for that customer going out the door, their ability to afford that drug. And that to me needs to be the highest priority for us. So to have some way of looking at that, ranking in that sort of way. I'd like to see this work, it really needs to be consumer driven in terms of how do we make this possible for that individual to afford their drug. And when you had to go to the drugstore and pay $900 for a drug, some people can do that, some people can't.
Well, I'll just say that at first I was thinking that we didn't really need to add in any of our own personal rankings. But I think, Doug, you made a very good point on how so many of these, what we're measuring here, are really tied together because of the number, like if it's a high number of people and a high cost, that it's the out of pocket and what the plans are paying are going to both, they're kind of the same thing, really. There's percentages in it, but it puts both measures go to the top. But I still need to think about how because I also like the idea of simplicity and trying to keep it as simple as possible. So I'll have to think about which direction I think to go.
Can we try the ranking? I have a feeling that if we do the ranking and then we pull it up and compare it to this, we might see a lot of overlapping. And so is it the 26 drugs that we can choose from? I think the majority of them will be on there for us to choose from.
So then I think I'm hearing the general consensus is so we can go forward using the summing of the ranks and then applying our weights to that. So we distributed our points among the board members, and then basically we can. I'm just thinking out loud here. So times the rank by if the first one got 75 out of the 100 points, times that by 0.75. Next one got 10 out of the others, times that 0.1. Then add those together to get the new sum is kind of the idea behind that.
Yeah.
Okay. So Jinping gives us the thumbs up. Ryan, Donna, as our pharmacy experts, any thoughts, ideas, questions, concerns on that?
Not right now. I think it is possible, and I'd be curious to see, kind of how those weights and scores come out, and then from there, we could put it together. I wonder, and just kind of thinking about what you were saying with the different weights, I'm wondering that, if we look at the rank for like the most costly is 1, and then the next most costly is 2, if the most costly is like $100 million and the second most is only 1 million, is that important for you to differentiate at this stage, or are you okay with just having the rank of 1 and 2? Because then that would also require some adjustment in the methodology to account for these differences in scale.
Well, because I think though, Ryan, because when we rank it and it comes out and we get our top 25 or whatever, then we won't be worried so much about the weights per se anymore. But we'll have that top 25 and we can see the 10 million versus the 1 million, and then looking at it, the board can say, oh, this 10 million one is speaking is obviously way ahead of the others and is speaking to us.
Right.
So I think that when we bring it to the next step is then we're just looking at the list. And then we get those binaries and does this have a therapeutic equivalent? Yes or no? does this have, does this meet multiple thresholds, which might be important to someone?
Yeah.
So
this, I completely agree with Mike on this. I guess the one question I have is like, so when I submitted my weights, it was for 6 variables, including the 2 binary. So do we need to?
I think revise that and do it for the 4, and then again have the 2 binary be more kind of the informational on the side as well.
I'm okay with that, but it is effectively making the 2 binary the least most important. And I was already kind of close to that anyway, but I don't know how the rest of the board feels. So
there's a question in the chat or the Q&A box that you might want to look at.
I can't see it.
Is there a difference between the 5 variables chosen for weights against the 6 selection criteria for deciding whether to conduct an affordability review?
basically what we're deciding.
Yeah, I'm just.
Because I guess we just need to decide if we're okay making therapeutic equivalent availability and generic availability, as well as multiple thresholds tiebreaker, but then putting them in a tiebreaker category rather than having them in our base ranking. And yeah, like I said, I'm okay with that, but yeah, I'd like to hear the others.
Yeah. Dave. Marianne, Eileen.
Yeah. Yeah. I mean, I can go with that. Yeah, I'm fine with that. I have a feeling that we're going to be tinkering
Yeah.
a bit more as we run these.
I'm fine with it.
Okay. Any other thoughts or questions then?
It really only does effectively matter if there's a tie between the 25th drug on the list that doesn't make the criteria. And it's extremely unlikely that this decision will make a difference on that. So.
Okay. So then I think we kind of have a direction then. So we'll go with weighting the sums of the rankings, with the 2 binary choices being, more informational afterwards. And then I think with our new board member, Greg, maybe do we want to, because now that we got all 5 here, for our last meeting, we didn't know that Greg was in the running here. Do we want to redistribute the points and do 20 per board member and then have everyone then vote on or give those points on the 4 measures?
I think that's fair. We should do that.
Okay. And so then that way for our next meeting, then we can come with our weighted and ranked list here for the board to review. And then we'll have the whole list, but I mean, do we want to, I guess, focus on like the top 25? And I was just saying a number, just to keep it within,
we can only conduct 24 affordability reviews per year, right?
Well, yeah, and then that's going to be another question for our next board meeting is how many do we actually want to do? In terms of capacity wise, I can give you a pretty solid promise that I don't think we'll be doing 24.
My point is just that only those top ones are really relevant.
Yeah. So yeah, we can have the whole list, but maybe we can discuss and focus on just those top 25, then to try and whittle that out. Okay,
sounds good.
Sorry, so just to make sure I understand my assignment. So each one of the members will have 20 points to distribute for ranking. Is that correct amongst these 4 variables?
Yes, sir.
Okay, gotcha. Thank you.
Yeah, and we'll send everything out here in email with the details. And Greg, we can chat. I know you weren't here at the last meeting where we were kind of originally putting this idea together. But now that we're flushing it out more, yeah, I can catch you up on any details or questions that you might have.
Okay, that'd be great. Thank you.
Okay. Any other thoughts or questions around that? Doug, I can see you're having.
Yeah, I just think that like the 4 variables, total number of users, that's total numbers of people with at least 1 claim. Okay, average member paid amount, that's average member paid amount per month among people with at least 1 claim in that month, or at least among people with at least 1 claim in the year. Okay, so you can have 0 months as well as let's say if you use it in January, then you'll have 0 for the rest of the months. Okay, then member paid amount is basically just it's essentially column 1 times column 2, right? Number of users times the cost per month.
No, because the number of users is different than the number of claims.
Right. Okay. So, but it's not isn't column 2 is amount. Is it amount per claim or is it amount per 30 days? Per 30-day fill.
Do you know if that's per claim per 30 days or per year? Column 2, the average member paid amount.
Together during a year, so that's the per year.
Okay, but so should that be per 30-day supply rather than per claim?
I don't think it's the utilization per year, right?
Is it?
It didn't mention like.
Oh, so is it just average annual out of pocket for anyone with at least 1 claim? I'm fine with that too. I just think that we want to be clear about this. And then column 3 is so then in that case it is column 3 is just column 1 times column 2. Yeah, grab a couple of these equations.
I want to say, Greg, if you have questions too, feel free to chime in. I just want to make sure you're staying, getting the information and answer that you need.
Okay, yeah, thanks. I don't want to overstep. I'm not an official board member. I don't want to be chit-chatting all day. I think I'm good. Thanks.
Slide 18, right? It's the relevant one here.
Yes, I think there's 10, 18, and then 16.
Okay, and actually that simplifies things because then you don't have to worry about if the claim is for 60 days or 30 days or whatever. It's just out-of-pocket costs in the full year. Yeah. For anyone with at least 1 claim. And then the final column is just total paid. So total out-of-pocket plus total plan. Okay. Sounds good.
Okay. Okey doke. Any other questions on our waiting next steps then? Okay, so next time what we can do is we can come here, we'll readjust the weights here, especially now that we have our new board member. And then we can come with that weighted list based on the ranking. since we've got that all kind of ironed out now, which I think is going to be a little bit more of a straightforward way of being able to get this list put together than other ways that we could have possibly done. And yeah, we can come and with that list and just kind of start talking about actually, how many drugs we want to select and what drugs we want to be looking at as well. So I think that'll be a lot of good discussion, really moving us towards the actual affordability reviews. So then we can do the actual selection early next year and start on that. So sounds good. And then we can also make sure we get the policy for exactly what we're doing and how we're doing that together as well. So that the actual written part of the here's how we're running things. So
the equivalent of the document that we talked about earlier.
Exactly. So developing our policy and our methodology for each stage of this drug selection and review process. Okay. So that takes us on to our next piece. Does anyone need to take a short break, or we want to just keep going on? We have two more pieces left, I think, for the meeting today. Plow through? Okay, great. So then this is your spot here.
Okay. I'm not offended.
Just give me a little whack on the back of the head if I'm getting too excited.
That's all right. So the next agenda item, Marina is going to talk a little bit about the affordability review draft outline. Marina.
Okay, let me share my screen. Let's see. Okay, is that coming up on your end? All right, great. So the next topic we're going to discuss is about affordability review outline. So I know selecting drugs, that's the more pressing matter here right now, but we also want to plan for the future when we have to conduct affordability review. And the first step is to solidify your wants and needs to conduct the affordability review. So a few months ago, I reached out to each board members to ask what kind of information you're looking for the affordability review. That was a very broad question. And I also sent you a copy of our legislation language. So our legislation lists certain factors we have to consider as part of the affordability review, but we can also consider additional items if you want to, or if anything helps you to determine the affordability of the drug. So let's start. So really the objective today is, let me see if I can hide this somehow. So the objective today is just to introduce and to discuss the outline for the future affordability review, and also to collect additional interests or suggestions that you may have. So again, really we want to solidify what you need and what you want to see for the affordability review here. So no voting needed, and I'm picturing this is gonna be a work in progress all the time. As we move on, we'll collecting different feedbacks, inputs from our stakeholders as well, and hopefully we'll keep making improvements in the process. So it's not gonna be like a set. I don't think it's gonna be any like set form, but especially the first few years, we'll see how it goes and we'll keep making changes based on what's working and what's not. All right. And let's see. All right. Yeah, so just a very overall process. So right now we are in the preparation. We are trying to develop data correction form on our end. And again, I reached out individually and kind of gathered your input. So now you'll get a compiled list today. And also another thing we have to do is to set up a secure portal for stakeholders to submit the proprietary or confidential data or information to us. So that's also ongoing in the background. And Greg, I know you're a new member and I didn't have a chance to reach out to you. I'm sorry, but you'll see what's compiled so far. And if you have any additional requests, feel free to reach out to me and I'll make sure to incorporate whatever the suggestions you have. So. All right. Okay. And yeah, so we'll be creating a secure portal for data submissions. We'll be creating the data templates and also information submission forms for each stakeholders. And also we'll be conducting surveys among different stakeholders, especially like the patients, advocacy groups, subject matter experts, so that they can help you make the decision at the end. And also, so that's all the preparation we have to do first. And we'll collect information doing surveys. And also there will be some steps that we have to verify the data on our end. And also we may have to hold some meetings in case any questions come up from our stakeholders. We may have to set up some one-on-one if they want to discuss some confidential data with the agency. And we may have to some group meetings together if any clarification is needed from the patient advocacy groups. So I'm assuming, just like do a survey and that's it. But I think we'll do a survey, we'll look at the data. If further clarification is needed, we may need to set up some meetings. So that's going to be step 3. And then all the information compiled, analyzed will be presented to you at the end. So again, this is going to be a long process, I'm imagining, and any patience and any guidance from every one of you is appreciated. But this is the overview. And so for the today, what you'll get is a compiled list of what kind of information you want to see for affordability review. And how all the elements or factors compiled is one, based on the legislation requirements. So the legislation spells out the board has to consider element A, B, C, D to do the affordability review. So that's part of the outline for sure. And also any special requests you have is now compiled into this outline. So you'll see that. And also I reached out to the portal, our external consultant members to get their advice. And also because we are also developing the data collection forms sheet for stakeholders, I reached out to other states PDAP and also states without PDAP, but some states doing a drug pricing review. So we collected some forms that they're using to see some of their language that they're using and also like a formats for the table, so that something will be consistent between states for our stakeholders. Yeah, so everything is now compiled and now we're getting the outline for the affordability review. And one thing I want to point out is we as an agency, we do not have all the data we need. So we have to reach out to our stakeholders, including manufacturers, patients, carriers, payers, PBMs, and also perhaps wholesalers again also. And also we are going to get some internal data source, including FDP Medispan, all payer claims data, DPT data. So DPT is a drug price transparency program. It's like our sister program we have at the agency. And they do collect data from manufacturers, PBMs, payers. So they do have some data that we may be able to use. So we'll use that to verify whatever the information we are collecting. And also we have contracts with other external consultants. So we'll get their guidance as well as we move on with the affordability review. And manufacturers, they have a fine if they do not submit information to us, but not other stakeholders. So here, I'm hoping this is like a wish list. We hopefully will hear from everyone because it can affect all the parties listed here. But we may or may not get all the information depending on the drug or the timing or how much help we can get from each stakeholder. So this is our wish list, but we'll see how it goes. All right, and this slide and next slide gives you the first headline of the outline. So just the big sections of the affordability review, starting with like a background information, efficacy, safety. So it starts from section 1 to the next slide has up to section 16. And I kept the language or the wording from the legislation. So I didn't really edit the wording. It's just as it is from the legislation. Okay, but I just want to go one by one. So for like, let's say section 1, it's gonna be just the background information about the drug. So we'll just list on our report what is a generic name, what is a brand name, drug class, NDCs under review, and also indications, approval dates by the FDA. Do they have any orphan drug status? So this is just a reminder. So we are not reviewing any drug with the orphan drug status only. If they have multiple indications and one of them has an orphan drug status, that's still eligible for the drug review. So yes, we may have some drug having the orphan drug status as well. And we'll also check on the drug shortage status, and also we will need some manufacturer contact information as well. So this is just a quick background section. That's the first. And yes, we are all, I think many of you are clinicians and have a clinical background, but we may or may not be totally familiar with the drug being selected. So we are going to collect some information about the drug from the manufacturers, asking, okay, what does this drug do? What is the efficacy? Is there any safety concerns we should be aware of? So this is, we're not checking the efficacy or safety. This is more for our education and for the education for the public as well, because at the end, the report is going to be available to the public. And I just needed some sections to educate about the drug, not just only for the board members and us, but also for the public as well. So I'm assuming this is just some brief few paragraphs talking about the drug. Okay, and this is a big part of the affordability review. So it's about the drug pricing information. And some of the pricing is spelled out in the legislation, and some of the pricing requested by you. And this is the list. So we are going to get WAC, AWP, NADEC, AMP, and also looking at the whole therapy duration, what is the most apparent WAC. Also, we are going to correct information on any discounts, rebates, and I heard the net price is gonna be, I think that's the one that's gonna be really helpful with all the rebates, discounts going on. What is the actual net price? So we're gonna ask that to the manufacturers, wholesalers, PBMs, and also we are collecting some data on the drug pricing in other developed countries as well. So we'll have a whole picture of what kind of pricings are out there. And also any other discounts, special discounts the manufacturers are offering to some special entities like 340B. We'll be collecting that. So these are all pricing information we'll try to collect. We don't know how much information we can get, but we'll see. But this is the whole list that we've compiled so far. And the next section is about manufacturing, delivery, administration costs. So we are going to ask, okay, what was the cost for the research and development and to keep product producing or manufacturing the medication? What is the cost to keep the supply? And also we'll be asking, okay, what is the marketing, advertising, or lobbying budget or expenditure for the drug? And also, if there's any delivery cost associated with the selected drug, we'll be collecting that information as well as the cost of administration. So this is more like a syringe for injections. We are not selecting any drugs that's administered in the hospital or infusion center, those are not eligible for affordability review. So by here saying administering cost, it's more like a syringe and other supplies. And if the manufacturers have any other administrative costs, the last one is just kind of catch-all information that I couldn't think of, then they can still submit that information. So this is section 4. And also we want to look at the cost to patients. And this information will most likely come from our payers or carriers. We'll ask about what's the patient's copay, co-insurance, and also we can look at like their premium, deductible, and also the average amount responsible by patient by claim. Some of these information are not drug dependent. It's more like whatever the medication we are going to be selecting for affordability review. It's not, the information may not be specific to that, but I'm hoping that we can kind of sort out the patient groups with that medication and patient groups without that medication and how many of them like reaching their out-of-pocket maximum or something like that. So we'll sort out hopefully with the carriers and payers and get some additional information for you about cost to patients. So this is the section 5. Okay, and the section 6 is a price effect on consumers' access to the drug in Washington. So this is looking at more like a state-specific information. So we want to look at, okay, what is the prevalence or incidence rate for the indicated conditions in our state? And also we want to look at the utilization of the drug in our state, and also the cost. Are they different from the nationwide? Are we like a super user of the drug or super spender of the drug? So we can take a look of that. And I think the coupons and patient assistance program discussion already came out, but again, we'll collect that information. So what is the patient's eligibility? What kind of availability for the assistance programs? So we'll gather that information as well as the actual dollar amount that they're providing or the quantity of the drug that they're providing through these programs. And also we'll gather information on the coupons, are coupons available? And if it is, what are the potential limitations to the use? So those are the information we'll be collecting from manufacturers. Okay, and we kind of discussed this already, and you'll be getting the information at the point of the selecting drugs. But yes, as part of the report, we'll define whether they have any generics or biosimilars. So that's Section 8. And also we'll look at some therapeutic alternatives both for the availability and for the pricing of them. And again, for this, we have to look at for each indication. And it's a bit tricky to define the therapeutic alternative. The same class drugs, the same indication, same rating in the clinical guidance or guidelines, then yeah, that's most likely to be therapeutic alternatives. But it's possible that we have to look at different class of medications, but may have a similar recommendations on the clinical guidelines. So again, this is where we can get some help with the subject matter experts and also from patients as well. We kind of have to look at where it fits in the treatment landscape. What's the pricing therapy? Is it supposed to be first line, second line, third line, etc.? How strong the guideline recommendations are and the overall cost, as well as we want to look at the safety efficacy differences between the alternatives. So those are going to be summarized as well, hopefully with some help with external consultants as well. And the section 10, it's going to be a cost effectiveness analysis. So we'll ask for the cost effectiveness for each approved indication from manufacturers. And it's most likely they have some kind of model they created prior to the marketing. So we'll be asking for the model so that we can figure out how the drug pricing was done at the beginning, what kind of things were considered. And we also, as an agency, subscribe to ICER Analytics. So that's actually our preferred platform. If the manufacturers also subscribes to the ICER Analytics and they have a model there, that's probably the best best model we can get. And because it's so interactive for you to see how the pricing changes with different parameters. So hopefully that's something we can gather from the manufacturers. And this is still to be determined for different stakeholder surveys. Again, we'll be surveying the patients, medical or scientific communities for their expertise. And this, I think the survey content will highly dependent on which drugs gonna be selected. So we haven't actually developed any surveys yet. But this is to be done in the future, as well as we'll be gathering input from our advisory groups as well. So this is something to come in the future. And also the legislation allows us to collect any additional information from drug manufacturers. So what may help us is to figure out what kind of exclusivity they have on the drug, as well as the patent expiration date, if that's applicable. And also if they have any special like life cycle management, any cost associated with that, we want to collect it. And for each approved indication, yeah, we'll be collecting some market competition and context, some revenue information, and we'll be asking them for the budget impact analysis, and hopefully we'll gather the model on that as well. So that's section 14. And section 15 is about the PBM, the drug tiers system. Do they require any prior authorization for patients to use the drug? Is there any steps therapy they have to go through to get the access to the medication? So those information will be collected from PBMs. And the last section is just off-label usage. So if there is any off-label use of the drug, again, we want to know about it. So we'll gather that information as well from the manufacturers. And I believe this is the last section of the outline. And the last thing I just want to point out is what you want to achieve by gathering all this information. And the first step or first decision after you hear all the information is to determine whether the drug is having the excess cost or a potential leading to excess cost in the future. And what is excess cost means, it's actually defined in our legislation. So I put it here for your information. It's the cost of appropriate utilization of prescription drugs that exceed the therapeutic benefit related to other alternatives. Or the second bucket is defined as cost of appropriate utilization of drugs that are not sustainable to public or private health care systems over a 10-year time frame. So those are the two big definitions of excess cost. It kind of clarifies the definition, but still some wiggle room for you to define more specifically. And the portal members will be presenting on this right after me. So you'll hear more at the next presentation. But some of the perspectives for you to consider to determine whether to product pricing relates to excessive cost is one, yes, the cost relative to the alternatives, and also two is out-of-pocket cost, and also the impact to the access for the patients and physicians and other providers. But also we want to think about the whole system, the state's public, private payers, and Washingtonians in general, because if the drug is too expensive, again, that tends to lead to a higher premium. So everyone is paying, higher monthly premium to the insurance every month. So again, it's not just the out-of-pocket cost to the patients themselves, but also everyone participating in the healthcare system in general as a consumer. So that's a broader view about the excess cost, but just pointing out, that we don't want to just focus on the out-of-pocket cost to the patients. All right, and this is my last slide. So right now you have the kind of compiled list of the outline for the affordability review. And I think it's already pretty comprehensive because I reached out to every one of you and looked at other states and gathered input from our external consultants as well. But if you have any additional requests, suggestions, wants, needs, it's not too late. Please let me know. And if you can email me, that's probably the best, because then I can kind of do a check-off list when I'm creating the information collection sheets. So again, if you have any big items, that I wanted to hear about XYZ and it's not in the outline, let me know, and as soon as possible, because we are developing the information sheets or data collection sheets for our stakeholders. So that's what we're doing right now. And once we have templates for our stakeholders, we'll post it on the website, and we'll gather some inputs and feedback from our stakeholders as well. So that's our next step. So that's where we are. And I think that's it. Any questions or a burning request you have right now that you want me to know?
Any questions? Don't see any, so thank you. Thank you, Marina. Appreciate it.
Yeah, thanks a lot. That was a very comprehensive list. I kept on thinking of things I was looking for, then you got them all. So.
Okay, sounds good. I think you may have more detailed or specific requests once you see the information collection sheets. But I think in terms of big items are there. So I'll move on from here. Well, thank you.
And thank you. Is Dr. Roman?
The portal team is on, but I'm actually gonna request we take just a quick break. We have a technical thing to resolve.
Oh, okay. Okay, so we'll have a little break while there's a technical difficulty.
Maybe like a 5-minute break.
Okay, so 5 minutes, folks.